Welcome to the JOMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Welcome to the JOMA podcast. I'm your host, Dr. Jenny Berkovich, board-certified pediatrician and director of education for JOMA. If you have anyone in your life with food allergies, this is the episode for you. My guest today is Dr. Zoya Treyster, who is a board-certified pediatrician and allergy doctor. She works at Uptown Pediatrics in New York City. Dr. Treyster completed her undergraduate and medical school training at George Washington University, her pediatric residency at New York-Presbyterian Columbia, and her fellowship in allergy and immunology at Hofstra Northwell. Prior to joining Uptown Pediatrics, Dr. Treyster was a faculty member at Children's Hospital at Montefiore, where she served as the Associate Medical Director of the Pediatric Asthma Center for 3 years. Dr. Treyster has expertise in treating asthma, environmental allergies, food allergies, eczema, immunodeficiency, and autoinflammatory disorders. When not in the office, she enjoys reading, hiking, and spending time with her husband, 2 young children, and 2 dogs. And as you know, this episode is sponsored by Tovito. Please use promo code JOMA10 when you visit tovito.com. It's been such a great addition to my family. We've all really enjoyed watching all the different amazing Jewish content that Tovito has to offer. It was honestly a lifesaver on Tisha B'Av, so definitely something to consider getting before the next fast day. It actually makes a great gift. If something that grandparents or other gift givers want to consider. Hope you enjoy the episode.
Hi, Dr. Treyster. Welcome.
Hi, thank you for having me.
I have to be honest that as a general pediatrician, I don't want to say that I didn't take allergies like seriously as something that kids have, but I definitely started to take them much more seriously when I became a parent of a child who is allergic. So I started to learn a little bit more about it. My perspective has definitely evolved over the years. So I'm excited to, I think, learn a little bit more and maybe talk about some myths that I encounter often. To start with, what are the most common food allergies in children? And I'm curious if you've seen that increase over the last few years.
So it's a list of 9 categories broadly, some foods and some categories: milk, eggs, soy, and wheat. These guys you're likely to outgrow in childhood. And then the second batch, you're less likely. Tree nuts, peanuts, fish, shellfish, and sesame was added officially recently.
Sesame is one that kids are less likely to outgrow.
There's less data on it, but to me, it's looking more like peanut, tree nut category.
Have you seen these numbers evolve like over the last, I don't know, let's say decade or so? Or is it just something that we're better at recognizing and being more aware of?
I definitely think there's more. I haven't been an allergist for a decade or more, so I can't comment on what I'm seeing. I can say that my practice and where I've been practicing has shifted, but when I left fellowship, I didn't think I would end up being primarily a food allergy doctor. And I have become primarily a food allergy doctor just because of what walks through my door. So I don't know if that's representative. Statistically, food allergies are increasing. So we're also recognizing them earlier. So I get I get a lot of really small kids who react and are instantly sent to my office to try to figure out if it's real or not.
One of the things that has always seemed maybe a little bit controversial in my mind was the idea of testing for food allergies. So maybe talk to me a little bit about like the different methods for testing and why some may be more appropriate.
So that's a really important point. A lot of parents walk through my door and say, "Can you test my kid for everything?" Food allergy testing, in the way that I typically describe it, is in medicine, there are good tests and bad tests. And as tests go, food allergy testing is not very good. So it's essentially a coin flip, meaning the tests themselves do not tell us if someone has an allergy. They tell us if someone is sensitized. But essentially, kid could be eating a food, like you and I will probably test positive to foods we eat all the time, and it doesn't mean we're allergic. We eat the food, we're obviously not having symptoms. Sensitization does not equal allergy. and it causes a lot of problems to have positive tests. So realistically, it's like a coin flip. Like about 50% of the time, the testing is accurate, and 50% of the time, broadly speaking, it's totally meaningless. You really only want to test with a concerning history. They've done studies because in the past, we didn't do this. So there's a lot of kids who reacted, let's say 10 years ago, to peanut, and then were tested to tree nuts and very often sesame of all things, and have now avoided all of these foods for a decade. The tests without a history of reaction are really difficult to analyze. And then in the period of avoidance for older kids, you can develop allergies to foods that you probably would have tolerated. So usually when I catch kids at very young ages, let's say a very common allergen is cashew. When someone comes in having reacted to cashew, we test the cashew and pistachio because those are similar nuts. And then usually I tell the parents to feed all the other foods normally, try to push it into the kid's diet, and you can prevent allergies to really most other foods. That's not the case for kids who have been avoiding these things for years. Often they then develop through that period of avoidance allergies. So we really, really heavily discourage. Food panels should not exist in the world of allergy. I wish we could just get those taken out, but we really generally discourage testing to anything that a person has not had a reaction to.
That's really interesting. So really, I mean, this is a question I get a lot as a pediatrician because somebody maybe has a history of allergies in the family, has a sibling right with an allergy. And then for like the subsequent child who hasn't reacted, the parents are very eager, and understandably so, to find out if there's like what's safe to feed the kid. But what you're saying is that without a personal history of actually reacting to something, there's no benefit to doing a test.
There's no benefit and a lot of harm. So for those parents that are very anxious, what I usually say is the best way to prevent is to, one, I try to control eczema because that's a risk factor. So a lot of parents are really hesitant to use topical steroids, and I try to push them in the opposite direction to really kind of modify that skin barrier and make it a strong barrier to prevent sensitization through the skin. And two, if you have a family history or a history of eczema, the recommendation is to introduce foods early, meaning around 4 to 6 months, and keep in the diet consistently. If parents are really nervous, I'll literally just have them do it in my office.
Yeah.
There's no reason a pediatrician can't do the same and monitor. But realistically speaking, even in kids who are, we think of negatives as really reliable. So if it's positive, you come, you do a challenge, that's a problem in and of itself because pediatric allergists are not, there's just not that many of us. So in the process of figuring it out, you're creating delays in introduction, which put the child at higher risk. But the other factor is that negatives are pretty reliable in older kids. In very small kids who are just starting to eat foods, you can be negative and develop an allergy. So I always, of course, took food allergy seriously, but my youngest son has a food allergy. And that, of course, also changed my perspective. But I did everything right as a parent. I'm an allergist, so of course I pushed all the foods. At some point, he stopped eating tree nuts. I guess he just started having some sensation he didn't like. And he's my second child, so I didn't push it. I forgot all about it. And then when I reintroduced it several months later, he reacted. So his very first reaction was at 18 months. He tolerated it perfectly well, probably the first 10 or 15 times I introduced it. If I would have tested him at 6 or 7 months, he would have been negative. So really, even the negative testing, I think, just allays a parent's anxiety, but has potential to do harm to the child. So I really, really try to push away from that and try to think of it as, this is a parental anxiety. How do we address your anxiety? Let's think about how to do this in a way that's better for your child and make you less anxious without the testing that we know is not very helpful.
Let's talk about skin testing because I know that sometimes it goes along with blood testing, and sometimes I see allergists sort of skip that step. When is it indicated, and when is it a helpful part of the whole picture?
So if someone has reacted and we're trying to figure out whether we're trying to figure out whether it's actually an allergy and trying to actually stratify risk, I actually do skin I always start with skin if I can, and then I'll often do blood to have benchmarks. They really should be, the same in theory, but they're often not. Sometimes there's really broad differences between the two. They're helpful for us in following a child and trying really to determine if they have an allergy. One, if that allergy exists, and I can kind of get more into that. But then over time, we trend those numbers, especially for the foods that kids are likely to outgrow, to determine if we feel like it's safe to do an oral challenge. So your gold standard for determining whether an allergy exists or not is an oral food challenge, which is essentially we feed the food in divided portions over the course of, usually like an hour, hour and a half in the setting of an office. We do the testing to determine if it's safe to do a challenge when someone walks through the office. What I mean by that is kids present with hives, right? That's the most typical initial presentation. Kids can have hives for all sorts of reasons. They can have redness because of contact irritation. They can have poorly controlled eczema that leads to a confusing picture and really diffuse redness. They can have hives with a viral illness that just temporarily correlates and makes for a good story. So if the story is appropriate, you use the testing to determine essentially, is this an allergy? Or sometimes, if the numbers are 0, then you can proceed and do an oral challenge and determine, yes, it is, or no, it isn't an allergy. That's your way of essentially clearing and deciding what next steps are. If you start with skin testing and the skin testing is large, sometimes I just don't see the point of doing blood work, except if we're talking about enrolling the child in oral immunotherapy. And then, of course, it's necessary.
So let's talk about oral immunotherapy, because I also feel like this is something that's maybe become a little bit more prevalent, or maybe just it's my bias because now I'm a parent of an allergic child, so I'm looking into all these different options. What is it, and when do we do it?
Oral immunotherapy is amazing. I was always very pro oral immunotherapy, and then when my child developed food allergies, I became much more pro. So I called one of my colleagues and said, thank you very much. You're adding my child next week and he's going to start. So I started him a week later. And I often tell parents that because, I treat each patient I think about it as if this was my child. How would I approach the care of your child, which I think is how many pediatricians go about how we think about things. And I feel really strongly about oral immunotherapy for the right patient. So what it is gradual desensitization, where you start with very low doses of a food that a child is allergic to, right? You start with very low doses in a doctor's office. You go up in dose in a monitored setting in the office about every 2 weeks until you get to essentially a dose that's, we'll use nut as an example. So for cashew nut, essentially you go up to one nut, 1 to 2 nuts. That's usually the amount that we call maintenance dosing. So that's
by the way, I'm getting so nervous just thinking about this because one, it's a nut. So I'm thinking just from like an age perspective, right? Practically, it has to be somebody, I assume, who's like old enough that you can safely feed them a nut.
No,
is that part of the criteria, or is it powder?
Powder. Yeah, you can use powder. You can use milk. You can use the nut ground up.
I'm less nervous, but still nervous because I'm just thinking of my cashew allergic toddler. I'm intentionally feeding him cashew. So I recognize there's probably some component of like discomfort, I think, probably going into this.
Yes, there is discomfort. And again, you have to, I really try to I try to draw a line between what you're comfortable with as a parent and what is in the long term in the best interest of your child. Your child as a toddler, it's really easy to monitor their environment. That's not the case when your child grows up and goes off to college and is in Europe. So it's really hard for us to think forward, but I actually think of OIT as a critical window. Essentially the goal of OIT is not to free you of the allergy. We don't have enough data to say that that's going to happen. It's to make a child bite-proof. What that means is, let's say that they're exposed. So like yesterday, I had a patient. who's 16 years old, and he was served a piece of lasagna that had cashew in it. Why is there cashew in lasagna? I don't know. That was a new one for me. He, of course, had a reaction. Mm-hmm. So if you do OIT, the goal is that when you are served that piece of lasagna with cashew that is totally invisible and you can't taste it, you will not have anaphylaxis. So you don't stop carrying your EpiPen, but you have less risk of those reactions. So for a mom whose kid is in oral immunotherapy, I don't worry about labels that say may contain nuts. I have a lot less anxiety in my life over kids who are taking care, people who are taking care of my child. Mm-hmm. So I come from an immigrant family. I really struggle with, getting my parents to understand how to use an EpiPen. This is a new concept for them. Yeah. The older generation, there really was much less food allergy. And I think grandparents really, they want to do the right thing, but I think a lot of us would worry about whether our parents would actually use an EpiPen correctly. Daycare mix-ups, things like that. So I'm able to move through the world on a daily basis with a lot less anxiety because I know my child eats 1.5 cashews every day. He didn't start with 1.5 cashews. He started, the maintenance dose of cashew is around 300 milligrams. I took it a little higher than that, but that's most people. Everyone has a different protocol. The protocol my physician, the one I use for my son, because I don't doctor my own child, he goes to 300. We started at 3 milligrams. It was literally like a speck of cashew. And then you updose every 2 weeks. So it took 6, 7, 8 months, I don't even remember exactly, for us to get to where we are now. When you start at the very young ages, we don't promise it, but I think a lot of people hope that you can get the child to outgrow the allergy. And certainly the data on that is looking better. We do know that you stand the best chance of being able to do that and being able to influence the immune system the younger you start. So I always encourage parents to think about it in that way too, that, if you want to give your kid the best chance of tolerating the highest quantity, you want to start earlier rather than later. OIT is still very hard to find. A lot of people aren't doing it. So I don't do it in my office currently because I don't have staffing for it. I work really closely with another office that's a few blocks away. It's called Latitude. They're a startup that's based in California, and they're slowly growing. I hope they continue to grow. And all they were started by a mom whose kid had terrible food allergies and eventually outgrew it using oral immunotherapy. So all they do is oral immunotherapy, and I work closely with them. I'm in a big city area, so there's more access, but certainly access to OIT it's still a big problem, I would say, around the country, even in New Jersey. So I'm in New York City. In New Jersey, my colleagues, say that the closest OIT is still an hour away. Now, when you're thinking about bringing your kid in every 2 weeks
it's a big commitment.
It really is a big commitment. General, it's really like I start out every day fighting my toddler to eat what I need him to eat. So it is a big commitment in general, but I always think of it as like, okay, but this is what we have, right? So
right. And it's almost like an insurance policy, right? So you're doing the work up front to try and decrease the risk of a serious reaction later in life.
And what I found is that young kids in general will have more, it's not that they don't have anaphylaxis, but they certainly have less. The young adults, the teen and up age, I don't know if it's puberty, I don't know what happens, or if it's their risk-taking behavior. They have a lot of reactions, but it's not just the reactions. The reactions that they have really tend to be much more dangerous and severe than the reactions that you see in very small children.
And I think that's actually really critical to emphasize, because I rarely, but this does happen, see family that a child is allergic, has been seen by an allergist, diagnosed with an allergy, but they don't really take it that seriously because, he just gets a rash and we try to avoid it, but like we're not crazy about reading food labels. And I'm always trying to tell them that just because they haven't anaphylaxed before, that doesn't mean that it's like a minor allergy or not something that potentially could be life-threatening later on. So I always try to emphasize it to really, if someone has a true diagnosis of a food allergy, that is something you need to take seriously and really educate yourself about, labels and things like that.
Oh, yeah, that's something I hear a lot of, that, it's mild because he's never had anaphylaxis. Well, that's not what the tests tell us.
Yeah.
The tests tell us the probability of someone reacting, but not the severity of the reaction. So certainly if someone has had anaphylaxis in the past, they're more likely to have it in the future. But if you have not had it, it's no guarantee that you.
I want to talk a little bit about prevention. So I think there was a lot of interest around prevention. There was a big study that came out, I think out of Israel, where they were doing prevention through early exposure to peanuts, right? So they were doing Bomba or like Bomba-like puffs, right? Peanut-based puffs. And they, I think, showed that really you can make a significant difference in reducing the risk of developing an allergy to peanuts. And ever since then, I find that there's a lot of interest in prevention. So I want to talk a little bit about maybe that. And then you did mention eczema. So I want to double back on that and talk about why is having good control over your eczema important in the big picture of allergies.
Yeah, so this study actually turned the field of allergy upside down. We used to say to avoid foods.
Yeah.
So, our parents, when we were growing up, were told not to introduce allergens. And then what happened was Israelis found that their kids really had much lower rates of peanut allergy than the rest of the developed world. So they developed this large study, and the results showed really significant decrease in development of allergy with early introduction. So the kids in Israel have less allergy because they snack on Bombas from the time they're old enough to hold a puff. So that really changed our practice. And now we recommend introduction of all allergens early. I work within a peds practice now, so I developed a handout that I really just try to give to anyone who will listen to me. When we start food introduction in general, so keeping in mind that kids with family history, eczema, will often recommend starting as soon as they can hold their head up. My poor children had peanuts stuffed in their mouth as soon as they could hold their head up. So you introduce early. And then the second part, I think people hear about early introduction, but the part that hasn't made it yet to most parents is that you have to also consistently continue to feed the food. So what parents do is they'll introduce egg once and then they'll forget about it and there won't be any egg for 4 months. And then the child will try egg 4 months later and will react. So it's a lot of foods, and parents always ask me, how much do I need to do this? For prevention, we don't have data, we don't have statistics. I usually say to just, don't forget about it. Think about it, think about these allergens, make sure you introduce them, make sure you keep them in the diet consistently.
By the way, that was me. I was that parent. I thought I was doing a really good job. I got all the Bomba, I got all the egg, I got all the hummus because I wanted to make sure we were doing sesame. And I did it once and everything was great. And I was the perfect parent. And then I forgot. And then, oops, months later, we learned that he was allergic to all of these things. I find that sometimes I see, obviously, as a general pediatrician, I see a lot more eczema than I do food allergies necessarily. And find that a frequent conversation I have with parents is the eczema caused by food allergies? And it sounds like maybe it's the other way around.
It is not caused by food allergies. This has been a huge issue. So this has been researched endlessly with huge studies and lit reviews done on this topic. You do not want to remove food from a kid's diet because of eczema. Eczema is primarily a skin disease. When you approach eczema aggressively, I will, as a doctor, have kids with eczema. Eczema, it should be its own visit. The problem with Gen Peds is you just don't have time for all of it.
Yeah.
If I spend like a full half hour discussing eczema with parents, and then I bring them back. If it's severe, I'll bring them back a week later. I will bring them back weekly or every 2 weeks until it is better. Because on average, right, people hear 1 to 2 things that you say at a doctor's visit. It's really hard to remember everything.
That's why you need the handouts.
Yes.
I'm a big fan of handouts.
The eczema is really a problem when you feed foods. One, I do think it does put kids at risk for developing food allergy. We know that if you eat a food, if you're exposed through your if you're exposed by eating a food, your likely to become tolerant. If you were exposed through your skin, you're more likely to become allergic. It's just a different pathway. So when you have a broken skin barrier, which is essentially what eczema is, in theory, it does, I think, put kids at potentially higher risk. I will say that like the vast majority of my kids who come in with food allergies have some eczema, and it doesn't even have to be severe. I have one son with food allergies and one son without, and the son who developed food allergy had mild eczema. It wasn't anything impressive. That was really his only risk factor, and he was the one who developed food allergy. So one, I try to fix eczema from that perspective. Two, when you start feeding foods and you have a kid with eczema, it can be really confusing, especially for light-skinned children. They will often just have a lot of contact irritant dermatitis, which is where the food touches their cheeks.
Yeah.
And if they have that slightly broken barrier, the cheeks become really, really red. And then that becomes really confusing. So I have a lot of people who come in and think something is a food allergy because the kid's cheeks got really, really red or face got really red. And it can be really impressive. The redness on light-skinned kids can be really impressive. So I always talk to parents and say, you kind of also want to fix it for your own sanity, because as you're feeding foods, if you have that broken skin barrier, it's just going to be very confusing to know what is or is not a food allergy.
That makes sense. And I think also highlights the importance of early introduction and continuing to feed foods unless there's been a true reaction to it. I want to talk about something that maybe a little bit controversial, but I have had several times, even adults who have allergies tell me that if they smell a food in the environment that they're allergic to, they feel like they're going to develop a reaction to it. And I hate to invalidate like anyone's personal experience, but at the same time, for the physiology of that never made sense to me. As far as I know, food allergies are not airborne, but the people's experience, I 100% believe. Tell me a little bit about that, what I think is a myth, but why it feels like it's not.
Most food is not airborne. That is correct. The exception to that is when people cook fish or shellfish, and then it becomes airborne, which makes sense because you're cooking it and it's like literally in the air. So I have had patients who react when someone is cooking fish or shellfish. Otherwise, there's a strong just mind-body connection in general. I have a lot of patients who, it tends to be more adults, because we treat adults also in AI and do both peds and adults. So I've had a lot of adults who give themselves EpiPens and then go on to have totally negative testing because they're sure they walk past someone eating a peanut and they're sure their throat tightened.
Yeah.
I can tell you your throat didn't tighten, but okay, so that's a confusing story. That's a perfect example of where we use testing. They'll have negative skin and blood testing, and then they'll challenge them in the office and they'll pass with flying colors. So I think it's an anxiety that people have. When someone's allergic to a food, there's just this concept that they shouldn't be anywhere around the food. It's led to problems in general. It's led to problems with school policy. So a lot of schools are nut free, which is sort of random because that's just
one. That's just one. You guys just picked one.
It's like, they'll pick peanut and tree nuts, right? And then I had a friend whose kid was very milk allergic, and in daycare he would reach over and try to take other kids' sippy cups full of milk. So it's this really, it doesn't make sense as a policy, but also there's, within that has also spread this concept of allergen-free tables, where kids with food allergies are forced to sit by themselves, like with a friend at a table that definitely doesn't have peanut. None of that has panned out in the research to prevent allergic reactions, but it does cause social isolation and anxiety. So the problem with a lot of the ways in which anxiety is tied up in food allergy is the way in which it has influenced our behavior and policies and what it does to children. So anxiety is a very big part of food allergy. I also maybe fully didn't understand that until I became a mom kid with it. And it's probably something that physicians and allergists in general don't understand to talk about enough, because it's it is a chronic disease, but it's this hidden chronic disease where your kid just walks through the world and they seem totally fine, but you as a parent are totally panicking about it. You just have to be careful on an individual level, but us as a society also, that we don't craft policies that then go on to give kids overwhelming anxiety and social isolation for really no reason, for no without actual data that says that we're decreasing allergic reactions.
Well, I feel like that's true for a lot of school policies. Do you support any policy about minimizing or not having eggs or milk or something in a classroom at any age? Right. So I'm thinking even like smaller kids where I guess, there's a high risk of sharing. Would you support a policy if you know that there's an allergic child in that classroom, or that also doesn't make sense?
I think it makes sense to individualize it. So especially for the really small kids, like the daycare classes, if there is a kid with an allergy to something specifically, milk is tough because, but I think realistically, even with something like milk, if you told me as a parent whose kid does not have a milk allergy, that someone has risk of anaphylaxis in the daycare class, could you just not send milk? I mean, for the infants, obviously not, but it's not an issue for the infants, right? They're crawling, they're different. They're not individually really capable of stealing each other's food. For the older kids where milk is not necessarily a requirement throughout the day, I as a parent would have no issues like not sending it to the classroom. I think those sorts of individual policies make sense. Policies to have kids wash their hands before and after school make not before and after school, like before and
like
after
meals
makes sense. My oldest is going to kindergarten now, and apparently there aren't sinks set up for them to wash. This doesn't really make sense to me to have like peanut-free policies, but not hand washing.
Yeah.
Hygiene and maybe just more awareness and individualization to make sure you're actually protecting the kids who are at risk. That makes more sense. It requires a lot more effort and a lot more time to really craft a policy that's going to be dynamic rather than some blanket statement that covers the whole school. But that would probably go much further to actually preventing accidents.
I think definitely something to think about, but also to maybe reassure parents who are struggling if the school is not interested in implementing a policy that they feel that need.
I will also say that that's sort of my feeling. There's no data to support what I just said. I don't think enough places do it to study that. So if that was to be implemented, it would need to be studied before one can confidently say this makes a difference or not. Maybe everything I just said doesn't make a difference. Maybe kids would still have the same number of accidents. I don't know that.
I think it just seems much more practical and common sense. But I also recognize that it's requiring nuance, and that's not something that school policies necessarily excel at or have the ability to do, really. I want to end with asking about maybe what's next. What can we look forward to as parents of kids who are allergic? Is there any like new developments coming out or things that you think will sort of transform?
Oh, there's so much. So we didn't have time to talk about Xolair at all. Xolair was approved for food allergy. It's really a game changer for the very allergic kids. Really, I think most pertinent to kids who are school age and having a lot of accidents. The kids in my personal practice, I mean, I have like a slew of college age kids now who are on it. Kids, when they enter college, really will have a lot more reactions because of just cross-contamination. They have reactions when they go abroad. There's a lot of reactions in kids traveling throughout Europe. So Xolair has been a huge game changer. Again, doesn't cure the food allergy. It's an injectable medicine. It's like the way I describe it is like a blanket of protection, essentially. So it gives you just that little bit of protection. So if you eat that cashew lasagna, hopefully you won't have anaphylaxis. The data on Xolair is phenomenal. And now the phase 2 trials are studying Xolair compared to Xolair plus oral immunotherapy.
That was my follow-up question. Is this something that will phase out oral immunotherapy?
I don't think so. I think a lot of people thought it would, but like me as a parent, do I want my kid on an injectable forever? No, I want to see that he eats a food.
Right.
The other problem with Xolair is parents ask, well, how do I know? And I say, I can't tell you. I don't know. The only way to know is to eat the food, and who wants to do that? So I don't think OIT is getting phased out. There are people who really can't do OIT. They can't climb doses without reactions. And so adding Xolair to their OIT process makes it possible so they can actually do OIT. So that's the big change. The other new development, so there's a peanut patch that's in studies. There's other ways of, kind of doing exposure that are being studied. That's a big one. Peanut patch has been in studies for a while. There's really not much out on that. And then Neffy, which is the nasal epinephrine, was approved this past
just
Friday.
recently. Yeah, that's hot off the press.
So that's a really, really big deal because it's our first option that's not injectable. And a lot of people do not give themselves epinephrine because they do not want to inject themselves. So hopefully this will help. It is not available yet. It's going to be available, according to the website, in like 8 weeks from the time of approval. It's only available in the adult dosing. So essentially 66 pounds and higher for now, but hopefully it'll be approved earlier. People, of course, have been asking about the data. It's contraindicated in patients with nasal polyps, which is a pretty rare condition. But otherwise, the data is really good. The way it hits the bloodstream and the effectiveness is really positive. So that's something that we're very excited about. I think all of us will go to prescribing it, but of course, we don't have any real world experience with it yet.
Exciting. Okay, fantastic. To finish up, any last words, any pearls that you would want parents of allergic kids to know?
I think it's a really exciting and dynamic time in allergy. So a lot of parents with older kids who were told your kid is allergic, just don't eat this food. It's time to circle back, see an allergist, and see what the options are. At least learn about what those options are. See if your child should consider Xolair, should consider oral immunotherapy. It's something that would work for your family, if it's something that geographically works. Just learn what's out there and how it may pertain to your child. I'm getting a lot of patients back in the office now who were told something many years ago. And I hope, I sort of explained how much allergy has changed in the last few years. It used to be a very black and white field, and now it is entirely a field of gray. And so I really think of food allergy as personalized medicine, and we should all be going over as physicians who treat food allergy to treating it completely on an individualized basis and determining what is best for each patient. There's no one size fits all. So if you haven't, thought about your kids' food allergies in a while because you have felt like there's nothing to do but avoid, it's maybe time to at least get more info, redo the testing, and reassess.
I love that. Okay. Thank you so much. I want to thank you for coming on and sharing your expertise.
Of course. Thanks for having me.
Thank you for listening to the JOMA podcast. We welcome your feedback and ideas for future episodes. Send us an email at health@joma.org. Don't forget to subscribe, rate, and review us on your favorite podcast platform.